I must contribute in saying this, that we all must save lives by donating blood. Hello, everyone. I myself, Shanti Bhattacharya, I welcome everyone today in nursing webinar session. And the topic which we have selected today is adverse blood transfusion reaction. It's recognition. How do we recognize and how do we manage? Before we unfold the session, let me introduce Miss Srividya, who is a senior nurse manager from Somajiguda Yashoda Hospital. And I welcome Srividya in this session today. And let me also take the credit and privilege and honor to welcome our esteemed consultant, none other Dr. Ganesh Jaishetwar, who is our bone marrow transplant physician and leukemia specialist and Hemato oncologist. So, sir, I welcome you in this session. I know you are very busy. Out of your busy schedule, you have contributed your half an hour of time to us. So thank you for this, and not taking much of time. Why we have taken this session today is, I think in generally, this is one of the very vital quality indicator, nothing but this adverse transfusion reaction, or just a common reaction, which is little underreported. Maybe this is a high time we need to educate and raise the awareness among the nursing team and the healthcare professional. So before saying this, let Srividya start the session. Thank you.
Good afternoon all. My name is Srividya, working as Senior Nurse Manager in Yashoda Hospitals, Somajiguda unit. Not to waste a lot of time, I'm going to start the session. Today, our topic is adverse drug transfusion reaction and its management. So what is blood transfusion reaction? Blood transfusion is the introduction of whole blood or components of whole blood, which has transfused like erythrocytes, platelets, plasma, RBCs, FFP, cryoprecipitate into venous circulation through IV cannula, CVC, or PICC line or chemoport lines also. It can be transfused to any lines. What is reaction? The reaction is undesirable and unintended in the nature. It can be life-threatening too. Reaction is a process in which one or more substance, also called reactants, converts one or more different substances known as products. Products are like blood products and there its components also. Then how a chemical reaction occurs? Chemical reaction occurs with enters to the blood, carbon dioxide reacts to the water, produces carbonic dioxide.
So here, I would like to ask the expertise, Dr. Ganesh, opinion on the very first question. Like, we as a nurses, what we understand, like what is reaction, how it occurs during blood transfusion, like, and as you must be, having the experience on many situations where you have dealt all this, and you may be taking a lot of calls, maybe, or is that so that among all the 10 oncology patients, by default, 5 oncology patients will have this allergic or adverse drug reactions? What we would like to hear from your expert opinion, sir.
Yeah. So that's a very important and pertinent topic on not just oncology, but any hospital practices. Like blood or blood product transfusions are life-saving procedures, right? They are intended to, in a critical situations to safeguard vital functions of the body. At the same time, these life-saving transfusions can also sometimes turn out to be life-threatening complications.
Yes.
So the reactions, the transfusion reactions can be mild, moderate, severe, and that's not uncommon, as has been reported from many Indian hospitals, institutions, and organizations. As you correctly pointed out, the febrile non-hemolytic transfusion reaction, simple fever on blood transfusion, is so common that 1 in every 20 blood product transfusions can have this fever after initiation of transfusions. So the commonest is in fever. Second commonest is this is as per the world literature, probably the incidence of these transfusion reactions might be much even more in our set of practices. So the allergic transfusion reactions, transfusion related volume overload is 1 in 100. So that might be more in our subset. Then these are still manageable, milder kind of reactions, but the serious life-threatening reactions, fortunately, are less common. For example, transfusion-related acute lung injury, that is 1 in 10,000, or transfusion-related severe bacterial sepsis, that is 1 in 10,000. Mismatch transfusion, even in the developed nations like North America, Europe, the quoted incidence is 1 in 40,000. I'm sure it must be less here because we have less manpower and less automation compared to what is practiced in the West. So the mismatch transfusion must be more in our subset. The world literature evidence is 1 in 40,000. Then the bacterial sepsis, the transfusion associated infections, the commonest is sepsis. So more common is platelet transfusions, 1 in 2 lakh platelet bags, 1 in 5 lakh blood bags, RBC transfusions can lead to life-threatening severe sepsis, right? The transfusion-associated infections like hepatitis, HIV, the 1 in 1 million, so about that is less common. But fortunately, the severe life-threatening transfusion reactions are not so common, but the commonest are manageable, mild to moderate transfusion reaction, which everybody in the system, particularly nurses, are our pillars of our functioning in the hospital setup. So they are the key leaders of anticipating such problems, recognizing these issues right in time, and rectifying these issues by their effective intervention. So, and I congratulate you for taking this initiative. This is very, very important aspect of day-to-day nursing, not just oncology nursing, but any specialty nursing across multi-specialty hospitals.
Yes. So as you said, we have maybe during my experience or till date administration experience, I have not witnessed the condition called TRALI, like you were saying, 1 in 10,000, and the as per the survey and the incidences. Yes, Srividya.
Yes. Let's see the reactions to the blood. Like patient experience, some patients have allergic reactions to blood received during transfusion, even when given the right blood type even too. In these cases, symptoms includes urticaria and itching. Like most allergic reactions, it can be treated with antihistamines. Thumb rules are always, we have to check for pre, intra, post vitals are very important to check and document. Inform the doctor and document then and there. Ensure DMO visit the patient bedside to check the patient's condition.
So, sir, again, as reactions are common, and you were mentioning that allergic reactions are very common in nature. Sometimes we do not even identify. We might see patients are just developing the rashes. Maybe patients are developing some erythematosus or flushing of the skin and other symptoms. So, what are the guidelines like? Since I get to see in the clinical scenario that not every patient's pre-orders are very significant, and the orders are given like by default you need to give injection avil or solumedrol or hydrocort shot so that your transfusion tenure goes well. So what is your message on this? Should we seek for the order? Should we not seek for the order? Should the DMO seek for the order? What is their guidelines they should practice like?
That is again a very pertinent, important point you have raised here. So transfusion reactions, particularly the nursing team, should be well versed, aware of all different types of transfusion reactions and how to recognize what is the symptomatology, the presentation. The common transfusion reactions, allergies, fever without evidence of hemolysis, this can be managed with a in consultation with the on-call doctor, and also hemovigilance team. Transfusion medicine specialty should be alerted and should be notified of the event. But most of the common manageable transfusion reactions are manageable with simple medications. The pre-medication is a wrong concept, right? So,
Yes,
by
exactly.
giving the, everybody this evil hydrocot paracetamol before transfusion, that can mask the severe transfusion reactions, and the time to intervene can be masked, and the patient can land up with severe, catastrophe emergency later. So, as a rule, pre-medication before all blood product transfusions is contraindicated, should not be practiced. Yes, certain set of patients who are on periodic episodic transfusions and who have been known to be allergic, or who have been known to have certain antibodies, which for which it is mandatory to pre-medicate them with these anti-allergic, antihistaminic, and the steroids. Barring these select patients, pre-medication to prevent minor transfusion reaction, this practice should not be the norm, should be avoided. We should be well versed with the common transfusion reactions. We should have also, as you correctly pointed out, the trolley you have not seen, but the incidence is less, 1 in 10,000, and actual accidents doesn't come with a bell on their neck, right? But we should be aware of these complications.
Yes.
Who knows? You might be the next one to have witnessed such transfusion-related acute lung injury. This can be life-threatening. Again, having said so, if patient has respiratory distress, depending upon the patient symptomatology, just hives, rashes, itching, a little bit of fever, this is manageable with simple remedial measures. But beyond that, if patient has hypotension, say patient has angioedema, patient has respiratory distress, breathing difficulty, saturation is dropping, you keep on monitoring vitals on all patients who develop any transfusion reaction, and the patient is found to be hugely tachycardic, BP is dropping, then you should be alert, aware of possible transfusion reactions. If the patient has respiratory distress, secure the IV line, stop the, whatever transfusion reaction, interrupt the transfusion, check the labeling one more time, check all the pre-transfusion, variables, alert the hemovigilance team, run the rapid saline flush through the cannula, keep on monitoring vitals closely, keep an eye on the possible respiratory distress. If the patient has respiratory distress, order chest X-ray. Because these transfusion reactions, as I said, transfusion associated volume overload, not uncommon, 1 in 100. So every nurse is going to witness some or other day this transfusion associated volume overload, and you have such patient when you are not sure whether it is TACO, whether it is TRALI, whether it is anaphylaxis, give the pre-medication, do the set of investigations, alert the doctors, alert the transfusion blood bank, and by the time the rescue team arrives at the spot, keep on rescuing the patient. If the patient has progressive respiratory distress, put the oxygen on flow, give the diuretic, check the chest X-ray, call the doctor. While it's nurses have a huge, tremendous role in handling all this, because you are the one who are going to witness these reactions. You are the one who are going to be the first primary aid of anticipating, recognizing, and treating these patients, which is very, very important.
So as you said, just to understand and get to notify the allergies, I think one must always do the initial assessment completely upon the admission of the patient, and just know the awareness factor on the allergies or the previous drug allergies or blood and blood components allergies. I think if we just know this document, and I think we will be able to manage or prevent the allergic reactions. Yes, thank you.
Yeah, now let us see the classification of blood transfusion reactions and signs and symptoms. The blood transfusion reactions are allergic, febrile, and hemolytic. In allergic, we might see like mild flushing, hives, rash, severe anxiety, wheezing, and decreased BP, hypertension. Like in febrileness, the patient might have headache, tachycardia, tachypnea, fever, chills, and anxiety. As well as in hemolytic, there might be hypotension, the respiratory, increased respiratory rate, chest pain, lower back pain, fever, tachycardia, chills. Some common allergic reactions.
So I think, sir, if as Srividya has mentioned that allergic, febrile, and hemolytic. So these, I think we have seen these common conditions, and maybe it has been witnessed by oncology and other post-operative nurses in the critical care scenario and all. So what is your, management? What is what awareness you would want to convey to the nurses that how they should manage and what they should do? We do also have little protocol in very good protocol in defining what a nurse should do, but what other kind of good messages you want to give to the nurses here?
So most important is any reaction, any transfusion reaction, the transfusion should be interrupted. Stop the transfusion, keep the blood bag securely, hanging on the stand. Start running saline through the cannula. Check the vitals closely. See the progression of these symptoms. If it is just allergic reaction like you documented here, urticaria, rash, hives, just give some anti-allergics and see the response of the patient. If these allergic reactions resolve after these anti-allergic medications and the vitals are absolutely stable, the patient has no respiratory distress, BP is well maintained, patient looks clinically well, maybe 15 minutes down the line, you can restart the infusion at a slower rate and monitor closely. If there is reoccurrence of the symptoms, keep monitoring vitals and continue transfusion at a slower rate. But beyond these allergic reactions, patients goes on to develop angioedema, dropping saturation, increasing respiratory rate, increasing heart rate, or increasing respiratory distress, breathlessness, then you should not re-challenge with the blood transfusion. You should wait for the doctor to come to the bedside, check, assess the patient thoroughly, and then also the hemovigilance team, mostly the blood transfusion officer, coming and checking all the parameters. If the patient is continuously deteriorating, then that is not just simple allergic reaction. That can be anything of the severe reactions, blood transfusion reactions, and the transfusion should not be attempted. But the commonest, out of 1 in every 10, 20 patients, you get these allergic reactions. Might be more in our subset of patients. So simple anti-allergic medications, paracetamol, monitor for 15 minutes. If the patient gets relieved completely, restart the infusion at a slower rate. These small minor reactions, apart from notifying the respective authorities like hemovigilance team or the blood bank team, the duty medical officer, you can continue the transfusion if you are clinically sure that the patient has responded to the anti-allergic medications and the vitals are absolutely stable.
So, sir, I have one question. Like, do we get to see this dysphagia condition in allergic blood transfusion reactions or adverse blood transfusion reactions? Where we would find this reactions in form? Because we, as the slide says, urticaria, flushing of the skin, hives, rashes are very common in nature. But then what about the dysphagia? Do we get to see this patient as well?
Yeah, so anything like dysphagia, you should be you should have a high index of suspicion of possible angioedema, which amounts to severe anaphylaxis, right? So dysphagia, dyspnea, so breathing difficulty, swallowing difficulty, your suspicion for possible anaphylaxis should be very high, right? So that is not simple allergic reaction. Dysphagia, dyspnea, breathing difficulty, swallowing difficulty is a moderate to severe transfusion reaction. Take everybody into the picture, doctor, the blood bank team, assess the patient thoroughly. in the meantime, by the time the doctor and the blood bank team comes, give a shot of Lasix, put the patient on oxygen, start the IV saline line, and keep on monitoring patient's vitals periodically. Don't reinitiate the transfusion. Once everybody is on board, once the situation is completely assessed by everybody in the team, and everybody is sure this is not amounting to severe anaphylaxis or TRALI, then you can proceed with the transfusion. Most of the time, dysphagia, dyspnea, you should get everybody involved in the team for thorough evaluation and to make sure that you are not dealing with anaphylaxis or severe transfusion reactions.
Yes.
Let's see different type of reactions. Reactions can be developed during blood transfusion within an acute phase or days to week later or delayed in period also. Now let us see blood transfusion reactions and their types. Anaphylactic blood transfusion reaction. It occurs when the recipient severely allergic to something within the donor's blood. Example, the signs and symptoms will be like urticaria, wheezing, respiratory distress, angioedema, hypertension. The initial nursing management should be stop the transfusion, assess for the patient, then start the NS and inform to the DMO and blood bank team and recheck the blood labels and the patient labels to cross-check. And immediately, as per the doctor's orders, start the IV medications, start the NS, oxygen support, and if required, if patient is going to the worsen, start vasopressors even. And next, we have to see acute hemolytic reaction. Acute hemolytic reaction is when there is an incompatibility between the donor blood and the recipient blood. It is rare, but it is severe and life-threatening too. Signs and symptoms will be the chills, fever, flank pain, back pain, hypotension, red or brown urine, and nursing management would be the stop the transfusion, assess for the patient, again rush the NS and inform to the blood bank team and as well as the consultant and recheck the blood tags and the labels. Anticipating following, should start the NS, diuretics, and followed by the primary team. Instructions followed by the primary team. Next, followed by febrile non-hemolytic transfusion reactions. A febrile non-hemolytic transfusion reaction is when the patient develops a fever from cytokines, develops during the storage of RBCs. In these reactions, the signs and symptoms will be fever, chills, rigors, mild dyspnea. In this case, the nursing management would be stop the transfusion, same as assess the patient, start the fluid rush, and notify to the blood bank people, initially inform to the DMO, and start medication as per the primary advice and the doctor advice, and restart the blood if the patient got stabilized and monitor the patient very closely. Next, for the urticarial transfusion reaction. Urticarial transfusion reaction is a very less severe allergic reaction to a component within the donor blood, usually in serum proteins. The symptoms will be itching, rashes, and hives. Nursing management would be stop the transfusion, assess for the patient, start the IV fluid, notify to the blood bank and the DMO, and give antihistamines ordered by the primary team or the physician orders, and check for the vitals parameters every 15 to 30 minutes. And if patient symptoms were reduced, then restart the blood and continue to monitor the patient every 15 minutes. And now, it was a transfusion related to acute lung injury. As Dr. Ganesh sir said, it was very severe and we found 1 in 1,000. So here, acute lung transfusion related to acute lung injury was damage due to recipient neutrophils as a reaction to the donor blood. This is rare but very serious. In this, we have signs and symptoms of severe dyspnea, hypoxia, fever, and hypotension. In this case, the nursing management will be stop the transfusion, assess for the patient, rush the IV fluids, immediately call to the blood bank and the primary team, immediately go for the X-ray or other investigations ordered by the primary team, and if required, start oxygen support, IV fluids. If patient is going to the worsened condition, start vasopressors, secure airway management, and shift the patient to ICU. And next was the transfusion-associated cardiac overload. This is patient develops acute volume overload after transfusion of blood. These signs and symptoms will be dyspnea, hypoxia, tachypnea, lung crackles, hypotension. Here we have to monitor, mainly monitor drop factor. If we rush the blood at a time, like 300 ml per hour something, if we are not following draft factor, that may lead to cardiac overload also. Then here nursing management would be stop the infusion transmission and start assess for the patient, check for the O2, call for the medical doctor, inform to the blood bank, administer Lasix, and following start the oxygen support, go for X-ray. Important was strictly IO chart we have to maintain. If patient goes worsen, we have to shift patient to the ICU immediately.
I think these are the major adverse transfusion reactions which Srividya was just mentioning about. And I think as per your expert opinion, sir, like what could be the major worst scenario, or the as you get to see the patients when you initially assess your patient, and what precautions you want the nurses to take. You see a patient who is a case of ALL, and you might have the anticipation that patient might throw a hemolytic adverse transfusion reactions post or pre blood transfusion. What kind of preparations we need to prepare the nurses? What kind of escalation metrics the nurses should follow, or the DMOs in the floors?
Yes, that's a very important point. So basically, just before we discuss the nursing strategies and nursing preparedness to handle the common and uncommon blood transfusion reactions, I would like to highlight here, in one of the recent large-scale population surveying journal article, it was noted, this was again from North America, even there in a developed nations like North America, the awareness about various blood transfusion reactions, awareness, orientation, and the training to tackle such transfusion reactions, even the most developed nations, the most tertiary care centers, doctors as well as nurses, it was found that about 35 to 40% doctors and nurses in those tertiary care centers were not aware or adequately well educated for recognizing and treating such blood transfusion reactions. So it's a very important aspect and point. So, coming to our point, the nurses, as Dr. Srividya Madam has elaborated, these transfusion reactions, the orientation and training of all the nurses of possible transfusion reactions, their severity should be a continuous process, periodic training and assessing their competence in handling transfusion reactions and how they handle. So because these are not so uncommon events in our day-to-day medical practice. So the various transfusion reactions, the recognition of signs and symptoms, and how to act under these dire circumstances. It should be an ongoing training program across the nursing teams, and we should keep on assessing the nursing competence on handling such transfusion reactions periodically. So that's the way to handle and cope up for such transfusion reactions.
Rather, we should privilege them in identifying those symptoms.
Yes.
Yeah.
Next, a nurse should always act immediately when suspecting evident transfusion reactions. Notify the doctor and check for the complete vital parameters. Disconnect the IV tubings from the patient, but leave the bag and tubings attached. Do not discard the blood bag. Recheck the information on the blood bag and the equation. Document the event. Notify to the blood bank. Return the leftover blood products to the blood bank. Send the appropriate samples like urine, blood for cross-matching to the lab. Monitor the patient vitals as recorded until patient gets stable. In short, stop the transfusion, make patient attenders to be calm, and give them some psychological support that nothing is going to happen. We are there to take care of you. And next, start the NS through second line and inform the physician and escalate. Check the vital parameters, document then and there, and monitor the patient every 15 minutes.
Sir, here the already the patient and family members in little worry and panic state. So maybe few nurses may practice in flushing the IV line, few may not, because already allergic or some drug adverse reaction symptoms has been evidented by clinical team. So what do you suggest? Should we flush the line and go for the second new IV cannula, or how do we manage in this IV concept?
So ideally, if the patient is not very sick, it's not an emergent situation, you can try a second IV line and flush through like second IV line. But if the condition is emergent, patient is rapidly deteriorating, then it is not absolutely contraindicated that the line with which the transfusion was going on should not be used at all. You disconnect the transfusion bag, disconnect the tubing, keep it hanging on the IV stand, and put through the same line. If you don't have that much time or the venous access is difficult, you can continue running NS through the same line. Just before doing that, if it is a severe transfusion reaction, a hemolytic transfusion reaction, you need to collect the patient samples for assessing if there is a suspicion of mismatched transfusion. Patient and bag samples should be resent to the lab, to the blood bank for cross verification. But in the emergent situation, the same IV line with which the
Can be
transfusion
used.
one can be used.
Yes.
Next, important message for all the nurses, especially healthcare professionals, for the nurses at bedside. Hand washing is very important for the nurses and the patients even. Before we touch a patient and after the touching of the patient, we must go for a hand wash and wearing PPE. That is most important. And the last one is like keep calm and raise an incident. That is where we lacking. And here, the last one is one of the very vital quality indicator in the hospital scenario, which may be under-reporting as well. As to other patient safety, define transfusion safety nurse in the hospital who can audit, notify, train and report incidents with the help in doing RCA, CAPA with blood bank officer in terms of safety transfusion practices.
So, sir, with this new concept of thought process, I am sure that this defined position will do a lot of improvement, at least in notifying the incidences and preventing, because lot of in the hospital scenario, small, minor to major, observations are very happening incidences. So, what is your thought process on this? Because I think managing and treating your patients would also be better, and the outcome also will be super. So, what do you say about this? And
Yes, so transfusion safety nurse as a independent, authoritative person in the system to be vigilant about these reactions, to notify, to keep doing audits on such transfusion reactions, and keep on changing our strategies to handle, to manage such transfusion reactions is an essential entity in a large-scale multi-specialty hospital like ours. It is a must. And beyond that, we were just talking about simple blood transfusion reactions like blood and blood products. But beyond that, in a center like ours, we have active, oncology, hemato-oncology, bone marrow transplant program going on. So we have done more than 2,000 granulocyte transfusions over the last 7 years. So the granulocytes, when you think of rally happening 1 in 10,000 normal blood product transfusions, rally can be extremely high with granulocyte transfusions because you are infusing pure neutrophils, right? Which are the mediators of TRALI. So, and then not just TRALI, the nurses, I'm privileged to work with such a highest, competent nursing team by our side in our esteemed Yashoda Hospital, because we have more than 2,000 granulocyte transfusions. We have more than 5,000 Buffy-Coats transfusions over last decade. None of the transfusion was associated with any fetal or severe life-threatening reaction, because our nurses are so competent. By the time the product comes, all these granulocytes, Buffy-Coats have to be irradiated to destroy the lymphocytes. Otherwise, the transfusion-associated GVHD can kill the patient. So checking the irradiation status, checking the labeling, then giving appropriate pre-medications. As you mentioned, the pre-medications for granulocytes, pre-medications are must.
it is required.
So barring granulocytes, no other blood products pre-medications are mandatory. So adhering to pre-medications, checking all the pre-transfusion variables, monitoring the transfusions very vigilantly, closely throughout the granulocyte buffer transfusion. This I can say the beyond blood products, granulocytes, buffy-coats, apheresis products, the stem cell transfusions. These are the most stringent or the most demanding transfusions. So we have, fortunately, due to the most competent nursing and expert nursing by our side, we have not encountered any single TRAVI or any severe transfusion reaction in our practice because our nurses are very competent. So again, I would like to congratulate both Ms. Shanti and Srividya for bringing out such an important aspect of our hospital practices. And it's commonly said, again, I want to take this opportunity to, share and express my gratitude to all my eminent nursing team. When gratitude becomes essential ingredient of your life, miracle starts happening everywhere. And that's exactly what we have been witnessing over a decade at Yashoda Hospitals, Somajiguda. And again, the famous nursing quote, save one life, you are a hero, but save hundreds of lives, you are a nurse. So nursing is an essential pillar of hospital practices. And again, thank you so much for bringing out such an important day-to-day utility topic across the nursing practices. And I would like to congratulate Srividya for bringing out in such a very nice way, and Shanti Bhattacharya, madam, for putting things in such a very planned and very learned perspective.
Having your beautiful insight and those appreciative words towards the nursing department, it feels very great and good. I'm sure that nurses, the beautiful insight and thought process which is shared by you in this forum will be benefited to all the nursing department. And thank you so much, sir. I have seen your style of working, managing the patients, talking and communicating with the patients, and you have given your thought process in professional advancement for the nurses also, in academics, in welfare, every dimensions. Thank you so much. And Srividya, it is really good to see that nurses among all the Yashoda hospitals are coming forward for the webinar presentations and all. Thank you. That's how we end the session here. I think we've crossed fewer times here. And for the next Thursday, again, stay tuned for the new pertinent topics. Until then, thank you so much and have a safe stay. Thank you. Thank you, sir. Thank you, Srividya.